Well, as someone coming from the southern province of Canada, this is going to be fun. Uh, well, thank you very much. As many have said, this is quite the honor to be able to stand up here and present in front of such an amazing group of educators and clinicians. I'm going to talk a little bit today about the power of non-invasive ventilation, and kind of thinking back to the last presentation. This kind of goes into that systems 2 type thinking, right? I'm going to share with you some experience that I have from the pre-hospital setting as a paramedic, working in the field in flights for the last 15 years, and another almost 10 years before that. Just a little bit about me. In my spare time, I do like to do a lot of training. It's my family. Recently left the primary clinical field to work as a chief flight paramedic for a team out in Colorado, so I'm excited about that. Spend a lot of my time out with my dog mountain biking in Colorado, so just like to share a little bit about me. Quick disclosure, I was invited here by the team from Hamilton Medical, but I do teach a lot of mechanical ventilation, but I teach I'm very unbiased in the type of education that I deliver. I don't teach any one particular device. I teach mechanical ventilation because I definitely see it being a gap in the education from within our systems. So. I'm not going to stand up here, like some others said, and teach you about IPAP and EPAP and non-invasive necessarily. What I want to do is I want to dive into a little bit more of the thinking, the systems 2 thinking behind non-invasive ventilation. And I want to take you on a little bit of a journey here. I want to introduce this patient, and I want to ask you what you might think about this individual. So this was a 73-year-old male that I recently transported. Past medical history of COPD. He came into the ED in respiratory distress. Acute renal failure, acute liver failure, pneumonia, COPD exacerbation. His vitals were horrible. He had heart rates in the 120s to 130s. His respiratory rate was 40 plus. His systolic blood pressure was somewhere around 70. They started him on some noradrenaline, came up to the 90s. And he sat in this ER for actually, before I go into that, I just want you to kind of think. You don't need to say it out loud, but just think, what would be your approach to this individual? Would you be thinking non-invasive? Would you be thinking that he's too far down his disease path, we need to intubate him and put him on the ventilator? So I put the slide up here because in my world, this is not my reality. This is not the reality of the pre-hospital teams and the critical care transport teams. We don't have an endless supply of oxygen. We don't have an endless team, or presumably endless team number of people that can come in to help us. This is our reality. We have ourselves and our partner, and we're trying to do the best we can for these super sick patients. We might be in a helicopter out over the middle of nowhere. Until recently, in the US, we had these flow Venturi mask type non-invasive devices, and that led to a big complication in that we have limited amount of oxygen. We have limited amount of supply. And so when we are in this environment, we have to really think carefully about our utilization of resources, right? Do I have enough people to manage this person on non-invasive? Do I have enough oxygen to do this hour and 20-minute transport with flows that are 110, 120 liters, on something that's potentially delivering 100%? Depends on what the patient's demand is, right? This is the challenge that we're being asked to manage. This patient, the COPD exacerbation, who we know is going to be super sick, is really going to challenge us in this environment where we are limited in what we have available. The other thing that we are challenged by is this model of get the patient to the tertiary care facility, right? Short seating times, load and go, treat as you transport. And that's great in a lot of settings. Trauma patients, obviously, we know that they need to be in the surgical theater. We know that our COPD or our STEMI patients, they need to be in the cath lab. Our stroke patients, they need to be in interventional radiology. But sometimes that may not be the best option. And so I'm challenging the clinicians that I work with to shift their thinking a little bit more to when is it appropriate and when is it not appropriate to load and go and rapid transport. So I want to return back to this gentleman and and kind of think about what you might have thought. So when I arrived, I was called to transport this gentleman, and he's in the emergency department. The vitals are, as I told you. He had been on the non-rebreather mask for about 6.5 hours and was damn near, in failure. And I go and I get my report, and I talk to the emergency room physician, and I talk to the anesthesiologist who's still there, and I talk to the respiratory therapist, and they all say to me, "We think he needs to be intubated." And I said, "I think you're right." And they said, "But we're worried that he might arrest." And I said, "I think you're right." His pH was 7.0, 7.1, pretty close. He was very, very labile. And they said, we don't know what to do. And I said, "Well, did you think about non-invasive ventilation?" And all three of them kind of looked at me like I had just said something that they had never heard of before. And they said, "No, we didn't." And I said, "Okay, why don't we give that a try?" Now, these are three very well experienced, very knowledgeable individuals, but they got blinded by the fact that they were challenged by this individual. And mind you, this is a rural hospital in Nebraska in the U.S., and not a lot of resources, and they were pretty well overwhelmed, just trying to manage this patient and all their other resources. And I said, "That's fine. We all make these we all forget these things, but this is sharing knowledge. So let's try this." Now, this is about an hour and 20-minute transport from where we were to where we were going. And this gentleman, once we put him on the BiPAP, like I said, he was pulling like 110, 120 liters of flow. He was demanding 100% FiO2. He was very, very hard to manage. But there was another complication that we were dealing with in that the weather was coming in, and we had to make a decision. Were we going to stay or were we going to go? And if we'd stayed, we might not get him out at all. So we decided we were going to load the gentleman up, transport him to the aircraft, and try to manage him on our way to the receiving facility. So we move him out to the aircraft, get him loaded up, and while the pilot is going through his startup procedure, I'm looking at our tank, and I can just see it, our oxygen levels. Tried to make some adjustments and realized this was not going to work. So we aborted the takeoff, went back inside the facility. Inside the facility, I say, we need to switch the patient over to your wall, over to your ventilator. We depleted the batteries over the course of a little while. And the respiratory therapist says to me, "Okay, great, I'll go get the ventilator from the ICU." And I said, "Well, you've got the MR one right there. I know that when we bring that out." We'll come back to this scenario in just a little bit, right? So despite the evidence of non-invasive, in this particular case, the team just overlooked it. It didn't even show up on their radar. And this got me thinking, why does this happen? And so I started asking questions, right? And some of the answers that I got was, well, we just didn't think about it. I'm not as comfortable with non-NIV, and so I'm more comfortable just going to intubation. I don't have the resources necessarily to monitor this patient who is on NIV that might become apneic, might aspirate. And so for me, it was, we're just going to intubate. This is a better option for the patient. I want to ask you all to think about this. Would you consider a surgical airway in lieu of intubation because it's easier? And some might argue it's not easier. But we know that with the scalpel, we're guaranteed, or almost guaranteed, a secure airway. Of course we don't do that. We don't do that because it's not in the best interest of the patient. Right? We escalate therapy. Medicine is supposed to help the patient. It's not necessarily supposed to be easy. So the question I pose is, then why do we prioritize a more invasive procedure sometimes over a less invasive procedure that some of the studies demonstrate has a better outcome? Right? We shouldn't. So that's the goal of this, is to just get you to think a little bit more about how do we prioritize non-invasive, right? We know that intubation and mechanical ventilation has a lot of benefits, right? It secures the airway. We can deliver very precise tidal volumes and oxygenation. But it comes with risks, and we all know that, right? Damage to the lungs and hyperoxic lung injury and all the things that come with intubation and mechanical ventilation. And mind you, I'm not bashing mechanical ventilation. I'm a strong proponent of it, and I think across the entire industry we need to understand this. But with that, we need to understand those therapies that can prevent our patients from being intubated. So the question is not NIV versus INV, right? The results are quite mixed. We have to look at the science, and unfortunately, the science doesn't really give us clear guidelines all the time, right? We know that NIV is better in a lot of options, right? Acute cardiogenic pulmonary edema and using CPAP to recruit those alveoli, move some of that fluid out of the alveolar capillary membrane or out of the alveoli. We know that it's good with hypercapnic respiratory failure like COPD. And in our immunocompromised patients, we know that it has mortality benefits, primarily because of lack of infectious introductions to the lungs. We know that it's clearly not benefit in a lot of circumstances. Right? Patients in respiratory arrest probably should not be on NIV. But sometimes we just don't know, right? These hyperoxic respiratory failures, right? These ARDS patients, asthma patients, these encephalopathies. And these are those moments when we're really going to be challenged to apply our clinical knowledge along with our situational knowledge to this individual patient. Case in point, when I'm in the aircraft with a patient who has hypercapnic encephalopathy, it's 2 providers to 1 patient. And we're very closely monitoring that individual. That's great. So I might be more comfortable managing that patient on NIV, hoping to turn them around, as opposed to if you're in your emergency department and you're swamped by multiple patients, that might not be somebody that you have the resources necessary to manage. What we do know, though, is early proper non-invasive reduces pulmonary inflammation, reduces incidences of ventilator-associated pneumonia, reduces ventilator days, reduces ICU days, may improve mortality, and definitely improves patient experience. The evidence seems to be leaning towards a benefit to non-invasive ventilation over intubation. But even if it doesn't, even if it's equitable, all of these other things seem to mean or make me think that this is at least better for our patients overall or long-term care overall. The other thing that we do know is that a patient who is on NIV and they fail, they have worse mortalities. So this presents a challenge for us. Like, how do we determine those patients that will fail, and when are they failing? And how do we know when to abandon NIV for intubation? This starts with patient selection, right? Is this patient likely going to benefit from this NIV therapy? Right? Is this that COPD exacerbation who has only been in extremis for 30 minutes or an hour, or is this somebody who has been in extremis for 6 or 7 hours? Right? We know that the earlier we start this therapy, the better chances it has of turning our patients around. And that's a common theme that we've heard all morning. Starting earlier does better. Right? How severe is their disease? Right? When in these ARDS patients, studies seem to point towards a PDF ratio of 150 to 200, 150 to 175. Anybody less than that generally doesn't do very well on non-invasive. But sometimes they do. So give it a try. Right? Do I have adequate resources? That comes back to what I was saying earlier. If you're a nurse practitioner, sometimes we have nurse practitioners or physician assistants working in our rural hospitals, and they might have 1 or 2 nurses at night, and they've got multiple patients coming in. Do they have the resources in order to manage this patient who's on non-invasive that they have to monitor very closely before deciding to go to intubation? Maybe that's not the best option. Starting early, selecting the right mode. We have more modes available to us in terms of non-invasive ventilation now than we've ever had. Making sure that we're picking the right one goes a long way in making sure that our patients have good outcomes on non-invasive. Some tips that I've used that I've found really successful, and I get this question a lot, is where do I start? Right? I think that there's a there's a lot of confusion around non-invasive. Is where do I start with this? Do I start at 8/5 or whatever. And I always start slow, and that's what I tell the people that I train. I say, start slow, titrate fast, right? Because the whole goal is to make sure that our patients are comfortable on the non-invasive. That's another thing that leads to non-invasive failure. If a patient can't tolerate the mask, if this mask on their face is uncomfortable, they're going to fight it. So we need to do everything in our power to make sure that they are comfortable, right? So when I start on an NIV, I might be 2 or 4/2, just a little bit, but I'm not standing, I'm not walking away and seeing how they do for 15 minutes and coming back and titrating it. It's very quickly, right? Patient comfort. What kind of NIV interface do we have for our patients? What kind of information are we able to get to correct asynchronies? Right? Asynchronies are another bane of the patient who's on an IV. If we cannot adjust our ventilator to accommodate the patient's asynchronies, they will fail. Right? I love to say when I'm teaching people, I say, if you've got a patient who's intubated and they're asynchronous with the ventilator, and they're bucking the tube and pressures are high, what are you going to do? What are you going to do? Oh, I might mess with the ventilator a little bit, and that fails, and then what do? I sedate them. Well, who did we just treat? We treated ourselves. We didn't treat the patient. In everything, in all other realms of medicine, we titrate our therapy to the patient's needs. But unfortunately, I see it too often where we are making the patient breathe like the ventilator, not making the ventilator breathe like the patient. And so by using the tools available to us, we can actually titrate and fine-tune the ventilator to our patients. And this goes a long way. Patient ventilator asynchronies, there's so many of them, but here's the trouble. If you don't have the information, how do you know what's going on with your patient? How do you know where that asynchrony is? You don't. And so we're very fortunate now, in the last 5 to 7 years, where we're starting to see more ICU-capable, ICU-level ventilators make their way out into the pre-hospital and critical care transport world, and it is completely transforming our ability to treat our patients more appropriately and even keep them off of, prevent them from being intubated and run them on non-invasive ventilation because we have the data. I kind of stole this term from Dr. Scott Weingart. I'm sure everybody knows. He used to say upstairs care, downstairs, and I like to say upstairs care in the air, because that's what we're doing. We're trying to take the medicine that we know is effective for our patients and take that up into the aircraft and do good work. We have more information available to us, but again, when I train clinicians back in the States, this is something that I ask them, do you look at your monitoring values? And far too often, the answer is no, because I don't understand them. This comes back to educating, and why we're here today is to educate, and why I'm so honored to have the opportunity that I have with the students that I get to work with, is to teach them how to use this information to deliver better care for their patients. So back to our patient. I said we had to go back inside the hospital, put him back on the hospital's ventilator, and over the next hour and a half while I was waiting, we were trying to figure out how we were going to move this patient. I was able to actually look at the data that I was able to pull from the ventilator and start making fine-tune adjustments. And in about 45 minutes, I had this patient down where his respiratory rate was 21, 22, something like that. His CO2 was back to normal. His pH was 738, something like that. His heart rate had come back down to 80s, and he looked wonderful. Everything as far as his COPD exacerbation had corrected. And I truly believe that had we intubated him, he probably would have had a poor outcome. Now, ultimately, he ended up being still transferred because of the other complications that he had going on. But because I had access to the data and I was able to use it effectively, I was able to prevent this intubation. And I don't blame the team. It's this collaborative work that we do where we communicate, like the last speaker said. We have to communicate with our team and make sure that everybody's on the same page. Now, there are those times, and the data does support this, that if a patient is not responding to NIV, there is a moment when we have to decide, we have to abandon this, because if we continue down this path, they have bad outcomes, right? Generally, the consensus seems to be right around 2 hours. If I put a patient on NIV and I don't see an improvement within 2 hours, that patient is likely going to fail. If they continue to get worse, or they're not improving, these are moments when we as clinicians have to use our judgment and say, nope, this patient is not somebody who is going to improve. They're gonna do better on invasive ventilation. Right? Started just looking at a little bit about this, the patient's self-inflicted lung injury, and how does this play into our patients on non-invasive. Obviously, this is something that we need to be aware of, making sure that their tidal volumes are not too large, and if we can give them support, then we can hopefully correct that and prevent some of these things that are going to drive them to fail NIV. This is a slide that I put together just to kind of highlight, I know the respiratory therapist is a kind of an American construct, but 2024 numbers, rough estimates, about 3.9 million acute care providers. This is physician assistants, nurse practitioners, ED docs, paramedics, nurses, respiratory therapists. Only roughly 3.4% have any formal mechanical ventilation education. Yet, when you look at the vast majority of clinicians who are at the bedside caring for these patients, the nurses, the paramedics in the back of the helicopter or in the back of the ambulance, the ED physicians, that's the group that's the one that's actually here with the patient, taking care of them and managing their ventilation. And so I am a strong proponent of education, and we have to get people just to simply think more. Right? I'm not going to go into all this, but we all have this oath that says we're going to do what's in the best interest of the patient. We're going to do no harm. We're going to use our knowledge, and we're going to develop our knowledge in order to do better for the patient. Right? Our goal, our overall goal, and I don't think anybody would argue this, is that we want to send more people home. So, my challenge to you is, you have the choice, you have the power to choose NIV over invasive. It's not always a clear-cut decision, but I want you to think about it. Prioritize NIV ahead of intubation when it's appropriate, because that's the goal, is to send more patients home. That's all I have.